Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Jesse Higgins on older adults and substance use disorders, trends, and supportive interventions. My name is Bethany with CCSME, and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the positions of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all questions until that time and you can place them in the chat. And now I'd like to give a quick introduction to our speaker today. Jesse Higgins is the Director of Integrated Behavioral Health at Northern Light Acadia Hospital in Bangor, Maine. At an Acadia provider since 2010, Jesse has practiced consultative psychiatry in a family medicine practice at Eastern Maine Medical Center since 2011. She developed and directs an integrated program that leverages licensed clinical social workers and psychiatric mental health nurse practitioners on site and via telehealth in an outpatient medical practices throughout the state of Maine. Jessie is proud to co-chair the Bangor Area Clinical Substance Use Work Group, a clinical consortium that takes a collective public health approach to caring for patients and families impacted by substance use disorders, and serves on the board of trustees at Partners in Peace Domestic Violence Resource Center. With that, I'll hand it off to Jesse for our presentation. Thank you all for being here today.
Hello, everyone. Can everyone hear me okay? All right, full speed ahead. So we will just kick it off. So as Bethany said, I see patients in a family medicine practice. I do see patients occasionally in inpatient medical settings, sometimes in the emergency rooms. Prior to going to nursing school a million years ago, I worked in adult mental health case management in the community. But I do in family medicine practice care for a lot of older adults, and a lot of my practice is working with folks affected by substance use disorders. So our goals here today are to understand why we're talking about this as a discrete, distinct group of people, and what is the need for a specialized approach. What are some recent trends in substance use among older adults, and something called SBIRT, which many of you have probably heard of. We talk about this a lot with substance use disorders, particularly from primary care settings or general medical settings, that the first stage is screening and then some sort of brief intervention that can be done in just any kind of general practice. And then if you are referring someone to treatment or want to include someone on the treatment team, who would that be and what kind of approaches? And we'll also talk about, for those of you working as clinicians in the community with older adults, what can you do in your practice? So first, just aging in Maine. Maine is the oldest state in the United States of America. We have the most Mainers raising grandchildren, the most Americans raising grandchildren in Maine of any state in the country. Individuals 65 and older will make up 20% of the global population by 2050. And about in 2000, which was, quite a while ago, 25 years ago now, 14% of Maine's population was 65 or older, and it's more than doubling. So it'll be about 30% here in just a few years. So when we think about older adults, so the first point is this is a lot of our community. These are a lot of people I see. I know a lot of you who are here on this call see patients in rural communities. There tend to be more Mainers. When you look at that data, it's kind of skewed because, like in Portland, there are a lot of younger people. In some of the urban communities like Lewiston, there are a lot of younger people. But when you get into the rural communities, in some of the communities, the majority of residents are older adults. So baby boomers are changing the trend around older adults using substances. It's not to say that older adults using substances is a new concept, but it's more socially acceptable and more prevalent than it has historically been. Illicit substance use is far more prevalent among older adults in the United States than in any other country in the world. And overdoses in between 1999 to 2000 and now had nearly a 700% relative increase. Now, that's not all intentional overdoses. Some of those are accidental, and some of them are people using prescriptions and multiple prescriptions at one time. And we'll talk about that as well, how polypharmacy has sort of crept in. The most common substances abused are alcohol, prescription drugs, and over-the-counter medications, right? So although illicit substance use, which is, what we think of as like street drugs historically, like fentanyl or pills people buy on the street, or cocaine or methamphetamine, a lot of people who have been start using those drugs when they're younger, which is when most people start using them, don't live to be older adults or find recovery before they are older adults. So once you get to this age, the most common substances people are using are things either prescribed to them or to someone else. And often mixing alcohol with prescribed medications that they may take as prescribed or sometimes not as prescribed. So we think about older adults who use substances in two cohorts. So we just talked a little bit about the early onset people. So the people who maybe had an alcohol use disorder from a young age or have been heavily using cannabis throughout their adult lives. So kind of either continuous or had periods of recovery and then returns to use, but essentially have been using substances for a long time. There are also the other cohort we think about is late life use. So these are people who really didn't start using substances until they became older adults. When I was in graduate school, I worked in Kennebunk in a practice doing therapy for about 2 years as part of my graduate school rotation. And I saw a lot of older adults and couples who had recently retired. Many of them were people of money who had had like a Maine home and were now retiring in Maine, and they did not know what to do with themselves once they were home. There were couples who had been happily married for 40 years and now were not getting along at all. There were people who had been very busy, looked forward to retiring in Maine their entire lives, and now found themselves drinking a lot more than they had historically, or using cannabis a lot more than they had historically. Or other substances. So sometimes that's because of just that transition to retirement can be very difficult and stressful for a lot of people. What we know from the research, and I talk to people about this a lot, is that when you first retire, taking it easy and just chilling for about 6 months is generally not a bad idea. Take a break, you worked a long time. But after that, you kind of have to find something to do with yourself. Either you start volunteering or you work on a part-time basis or some sort of routine. You join a club or get involved in something in the community. You have to sort of reinvent and redefine yourself in retirement. So a lot of us, like the first question people often ask at a party, right, is what do you do for a living when you meet somebody? And it becomes, as Americans, for many of us, it's kind of a core part of our identity. And when you retire, you're setting aside a big part of your identity. So helping people figure out who they are going to be is incredibly important. When people lose a spouse or a partner, or have had, the traumatic experiences compound as people get older, right? If you live long enough, if you're fortunate enough to get to be an older adult, you lose quite a few people along the way under various circumstances, sometimes your children, sometimes siblings. And though as those losses kind of compound, there's a grieving process that it's difficult to manage without support. So people who are just trying to do that on their own will often struggle at times, and sometimes will find themselves using substances more than they anticipated. So, increasing use comes with increased consequences. So there have been significant increases in the prevalence rates, although these are not the most commonly used substances. the relative use of older adults of heroin, cocaine, stimulant use, methamphetamine among those 50 or older has increased in recent years. When asked what led people who had not historically used these substances to use them, people would say things such as pain. They'd cite their living with chronic pain, depression, anxiety, grief, loneliness, and social isolation. I heard a few years ago a school shooting survivor was asked in an interview what he thought if people needed to know one thing about people who are violent. What does he think that would be? And he said he was quiet for a minute, and then he said, "There is nothing more dangerous than loneliness." And I think about that interview a lot because I think it is so true in so many areas, not just dangerous to other people, but dangerous to ourselves. Healing happens in community, growth happens in our connection to one another. Even for people who are introverted, finding yourself another introverted person or two is pretty important along the way. So loneliness is a big trigger for use. These folks also are at increased risk. So you're using substances, if whether it's long-term use or you're starting use as an older adult, you're at increased risk in relative to a younger person to having serious health effects in your use. So you don't have to use as much or as often or in as high amounts to have these kinds of cardiovascular and cerebrovascular accidents. So stroke, heart attack, interactions between substances, and cognitive impairment. Really being careful. There are a lot of people who come in. I have an older adult relative who, has been convinced that he has dementia. He's in his early 70s, and he is heavily using prescribed substances. He's having the same one whiskey that he's had every night for the past 40 years, that he had after work, but now he's also taking medication for pain that is sedating, anti-seizure medication that is sedating, a medication for anxiety that's sedating, all at the same time. And it's impairing his cognition. So there's really no way of knowing whether without that cocktail of substances, there would be any cognitive impairment. So a lot of times that education can be really important. So there's increasing overdose deaths, as we mentioned, and also with substance use, there is increased risk of elder abuse. Partly because when older adults have these substances in their possession, they are more likely to be victimized by someone else in their family who they may be using with, or who is supplying these substances or using them as a supplier. They are also just more susceptible to being manipulated by other people, by family members. There's a lot of financial abuse that takes place. So, and then we think about Maine. Well, okay, so we're talking about Maine specifically, right, where we're all seeing patients, and there's many rural communities in Maine. A lot of these folks grew up here, have been here a long time. There is an increased need for pain management in these communities. Many of these people have done manual labor, worked in factories, worked on farms for decades, and that really takes a toll. It truly does. People are struggling to manage their chronic pain. There's a lot of depression and social isolation. It's not as easy to just go out to the coffee shop if you don't have a cohort of friends that have grown old along with you that you can talk to. It can be very isolating. If you have spent all your time with your spouse for your whole life and then your spouse passes away, it can be really difficult to form new connections as an older adult in a rural community. Transportation to get in is difficult, as you all know. Finding a therapist or a community support provider in rural communities can be very challenging. We want telehealth to be the solution for a lot of these people. For a lot of older adults, it is. People will say like, oh, older adults can't use telehealth. It's too complicated. That's not true. Older adults like to watch TV. They're often very good with technology. They have no trouble with a little bit of guidance, walking people through connecting to telehealth. That said, you do need somebody to walk people through step by step and not just send them instructions. That should be routine. But in some places in the state, even in some places in Bangor, Wi-Fi is poor. It's difficult to connect to telehealth by Wi-Fi, and that can be frustrating. Um, and there is for sure a shortage of addiction services that are set up to welcome older adults or have specialized services for older adults. And it can be very difficult as an older person to go into a treatment program or facility where everybody is decades younger than you. In the state of Maine, rural grandparents, people in our most rural areas are the most likely to be raising their own grandchildren. Often this is because they have a child who has struggled with mental illness or addiction, an adult child. And I have worked with many, many people, as probably a lot of you have, who saved their whole life in anticipation of their retirement, only to find themselves unexpectedly raising another generation of children. And that is how they're spending the last years of their lives. And that is a very challenging process. There is a grief process for the retirement that you thought you were going to have, even though these are folks that love their grandchildren to pieces. These are also often children that have been in a home where there was addiction and instability, so they are also in a period of recovery. So lots of stressors, hard stuff. We talked a little bit about trauma in older adults. Between 70 and 90% of adults have been exposed to at least one significant capital T trauma, some sort of severe abuse and neglect. One of the things when I first started seeing patients in primary care, I went back to the psychiatric hospital to talk to some medical students after the first few years I was there, and they asked me, one of the students asked me what most surprised me as going from seeing patients in a psychiatric clinic to seeing patients in primary care. And I said, it's the prevalence of childhood abuse and trauma. And it wasn't that I was seeing children, it was that I was seeing older adults who were disclosing for the first time in their lives the abuse and neglect that they suffered as children, that they had been trying to deal with their whole lives, and now they didn't have the distraction of raising a family and trying to work full time and doing all the millions of things you do as a middle-aged person, a young adult or a middle adult. And they were really struggling with symptoms of post-traumatic stress disorder. So people with significant trauma histories are often misdiagnosed. They're not diagnosed with PTSD or carefully screened for PTSD. So they end up prescribed medications for depression, for anxiety, for physical pain, because physical manifestations of pain is a symptom of trauma and post-traumatic stress for older adults. That doesn't mean that their pain isn't real, but the way pain expresses itself in our body, many of you have probably read the book, Your Body Keeps the Score. Trauma lives in our body for many, many years, and it affects the way that we experience our physical selves, including pain. And so if we're trying to treat pain and we're not addressing the trauma, a co-occurring or underlying trauma, you are unlikely to be successful. And we talked about role changes and functional losses that come with aging. So alcohol, again, is the most used. About 65% of people 65 or older. So 65%, more than half, when screened for what's considered problem drinking more. For women, that's typically more than one drink a day. For men, that's typically more than 2 drinks a day, or drinking at one time more than 5 or 6 drinks. 65% of people over 65 are doing this regularly and meet this criteria. The rate of alcohol-induced deaths among 55 to 64-year-old men is the highest. So 55 to 64-year-old men are more likely to die related to their alcohol use. That's partly cumulative, right? Because that's when things like hepatitis from a lifetime of drinking will start to affect you, but it is also excess drinking, having seizures, withdrawal symptoms. Remembering that alcohol withdrawal is one of the most dangerous types of withdrawal that there is, and it needs to be medically supervised. And then the second highest rate of alcohol-induced deaths is men even older, 65 to 74. And the rates among women are also increasing. So when I speak, often I speak to primary care folks. And even when I'm not speaking to primary care folks, I like to talk about it because many, many more older adults will present in primary care settings than we'll see any of us in as psychiatric or psychotherapeutic specialists. So universal screening is recommended for all older adults for substance use disorders. This very rarely happens. And if it does happen, often it's just like one question, like, do you drink? Do you have trouble with alcohol? Do you drink too much? Or not a validated tool. So we use the DAST and the audit in the practices where I see patients. I think I have those included here. We'll look in a minute. I think so. We'll talk about that more. But when screening does identify an issue, then treatment is rarely offered. They just sort of ignore it. Like they might screen positive and then they just move on like we did the screening. And that really, when we screen people for things and we don't follow up with a conversation that takes the screening results very seriously, it can create a dynamic where people feel like we don't care. And this was a quote from one of the articles by a gerontologist that's working with older adults with alcohol use disorder that I thought was impactful. Ageism plays a massive role in substance use, in particular for older adults, because healthcare providers don't screen. If you don't think that 80-year-old in front of you is drinking a bottle of wine at night, you're not likely to ask him, and you're not likely to do anything about it. So prescriptions, we all know, I mean, many of us probably have relatives or we ourselves are prescribed massive quantities of pharmaceuticals. It tends to be that the more specialists, the older you are, the more specialists you see, the more specialists like to do things. They are people of action. So when you go see a specialist, they're probably going to prescribe something or recommend a procedure, or rarely do they just say, you know, there's not much we can do here. So people end up with these very complicated, long medication lists. I explain to people all the time, you know, I can tell you in clinical trials and in studies what effect this pharmaceutical medication has on the people that were in the study. I can't tell you what it has on you in your unique biochemistry, especially in your aging body. And I especially can't tell you what it's doing in combination with all of these other chemicals that we're introducing into your body and how it's interacting with them. So it's very unpredictable and dangerous to have these long medication lists. There are fewer older adults misusing opioids than in other cohorts, but intentional and accidental overdoses are highest in people over 60, often accidental. But the rate, and we'll talk about this a little bit later, but the rate of completed suicides for older men is quite high, and that's something we need to be aware of with all of this. And then benzodiazepines, lots of people are prescribed benzodiazepines, older adults. They can be very dangerous for older adults, fall risk with opioids as well. The combination of opioids and benzodiazepines raise the respiratory depression risk significantly, which can cause death, people to stop breathing and die. People who are prescribed these substances, older adults, I rarely see Narcan being prescribed, but it should be. Anybody who is on high dose opioids or an older adult on any opioids, because it doesn't take a very high dose to be dangerous for older adults and risk accidental overdose, but certainly on a combination of opioids and benzodiazepines should have Narcan in the home, and there should be somebody in the home who knows how to use it. And then we have cannabis. Cannabis is everywhere now. It's in nursing homes. It's just all over the place. And I think actually even since earlier this year, Maine has more licensed recreational marijuana dispensaries. I live in Bangor. I can't drive like a mile in any direction without passing like 6 of them. They're everywhere. It's unbelievable. I don't know how the market is sustaining it because there never seem to be more than 1 or 2 cars in the parking lot of any of them. So I don't know how they're pulling it off, but I guess it's the pricing. But older adult cannabis users, lots of people call it their medical marijuana. I don't have any kind of judgment, moral judgment on cannabis use or frankly on any of this. But it is a risk to people's, it increases fall risk. Again, this is a chemical compound. People saying this is all natural. I mean, there's lots of things that are all natural that you should not ingest in high quantities, pretty much most things. So that doesn't mean that it's not having a psychoactive effect on them that could be dangerous. But people are definitely, I've had older adults come in and ask for prescriptions for medical, medical prescription because they just feel better kind of morally about it if they have that. But it's also cheaper if you have a medical license, and those are pretty easy to get. It's kind of a cash deal in a lot of places here in the state, which is also very strange. But these are the risks. So these are the things to talk to people about when you have older adults using cannabis. That side effects of cannabis for older adults are increased heart rate, increased respiratory rate. So people can feel like they're having a heart attack. And then there is a fourfold increased risk of cardiac events within the first hour after you've ingested cannabis as an older adult. Memory impairment, long-term cognitive impairment, difficulty breathing. So it's just important for people to know so they can make an informed decision and be careful. That prescribers often talk about with older adults, start low, go slow, and that is definitely true with cannabis with older adults. If you have an older adult going to the store and buying those gummies, like have a little tiny corner of it and sit there for a while and see how it affects you. Because for a lot of people who are just looking to relax, that's plenty. So trauma-informed care for older adults, I always like to talk about trauma-informed care. It's kind of becoming a buzzword. I don't care. I love it. I think it's so wonderful because so many people, at this point, almost everyone has survived some sort of traumatic event. Worst possible case, when you follow these principles, you are just being a nice person to other people, and welcoming them warmly. So setting the stage for recovery means, expecting that we've just talked about. There's a lot of people who are older adults who are using substances. If you're screening, expect that a lot of people will be using substances in a way that might surprise you once you start asking the questions and you seem like you are really interested in the responses. People will disclose things to you that may surprise you, but be supportive and welcoming of that trust that they are giving you. Be honest and straightforward with people. If we're trusting them to share their information with us, we should be honest and straightforward with them. Here's the risks. Here are my concerns. Here's ways to be safe. Think about harm reduction for people who want to continue using. Abstinence is not the path for everybody. We know that everybody has to find their own unique recovery path. Collaboration and mutuality. It's important to remember that people are resources, not objects, and not just participants in their recovery and in their care. I usually, when I first meet a patient who's just been referred to me, I say something like, this is your healthcare. This is your body we're going to be talking about. I'm here in your space, in your appointment to kind of help lend some clinical expertise, but you are an expert at yourself, and I'm going to depend on your expertise, and we'll work together to find a plan. And I always say to people, if you disagree with the recommendation that I'm making or something I'm saying, I really want you to tell me. It's not going to hurt my feelings. I usually say it's pretty hard to hurt my feelings. I really want you to be participating in this with me. And people usually get very emotional when you say those things explicitly because they're not used to coming into an appointment and being invited to participate at that level. They're kind of used to just waiting to be judged and told what somebody else's impression of them is, which is kind of neither here nor there. Peer support for older adults is wonderful. In Bangor, we have the Bangor Area Recovery Network, and we have the Together Place, which is a peer recovery space for people with mental illness and substance use disorders. Certainly, if somebody were to be interested, I've had older adults helped them connect with a peer recovery person in both of those organizations, really just by contacting them and saying, hey, I'm working with an older person who would like to connect with a peer and would be most comfortable if it was somebody else who is also an older person, and they're able to do that. So something to keep in mind, know your resources in your community. Certainly in empowering people to participate and advocate for themselves, and remembering that anybody who belongs to a marginalized community, whether that is a gender identity, a racial minority, or a socioeconomic, I mean, a lot of what we see in Maine is socioeconomic disparity, right? People being marginalized and having fewer resources and opportunities because of their socioeconomic status. So bear all of that in mind, because the more marginalized populations that somebody identifies with, the more likely they are to experience stigma and need to be supported along their recovery journey. So for healthcare organizations, we need to believe people who say that they're in pain. I am happy to be honest with you, I know there's different feelings about this in the community, but that we are moving into a more nuanced space of individual healthcare, where when people come in experiencing pain for whatever myriad of reasons, healthcare providers are more likely now, I think, to work with people on their individual risk factors and find a treatment and solution that will work for them with them. For a while, it was like everybody was getting overprescribed, and then nobody was getting any prescriptions, no matter what kind of debilitating pain condition they had. So we really need to think about people as individuals, and what kind of treatment options are going to work best for them and help them find their path. And then people taking controlled substances, often when somebody starts a prescription, they don't ask people, do you ever find yourself taking this prescription when you're not in physical pain? Maybe when you feel sad or lonely or having trouble sleeping. Are you ever taking it in a way that isn't like it's prescribed, like taking more than is prescribed in a day, or crushing it up and snorting it, or anything like that? Sometimes people do those things, and sort of making it possible for people to disclose, because sometimes people have had prescribed substances and been okay for a long time, and then something happens and they're not okay, and we need to keep checking in with them. And then really screening and educating providers, not just in primary care, but in the community, to coordinate with one another, and really in basic motivational interviewing, helping people, motivational enhancement therapy, to find their own personal individual motivation to enter recovery, whatever that looks like for them. Okay, good. So this is the audit, and I just included this here, and you guys will be able to have all of these slides. So we're not going to read through all of these, but this is 10 questions. I look like I forgot to number the 10th one, but I'll fix that. So this is what we use in primary care. This is what the audit is. It's just these 10 questions. The good thing about this versus some other ones you might be familiar with, like the CAGE, for example, is this doesn't just ask about chronic high alcohol use. It also includes binge drinking. It also includes using alcohol to cope in ways that might not, on it, if you look at like the number of drinks, seem like too many, but it's a pattern of behavior that is bothersome to the person. Takes 2 minutes to do this tool. They can either do it themselves, or you can ask them the questions. This is the DAST 10. So the directions on this say that this references substances other than alcohol and tobacco. So the other one is for the audit, and there's other screening tools for tobacco. And so these are the questions. This is just 10 yes or no questions. Again, just takes a minute or two. And this will give you a score. And what the scores tell you is this somebody at low risk of a use disorder, at a moderate risk, or at a high risk of a use disorder? And those scores are helpful, but truly, like, look at the questions, because their answers to specific questions are really important. So just looking at the score is probably not going to tell you everything that you need to work with them, but it's really good information. And I will tell you, I have people referred to me all the time for anxiety, for depression, because they've just been diagnosed with PTSD because they had a heart attack last year. And when I see them and we do the DAST audit, before I meet them at the beginning of the visit, it comes back that they are struggling with the prescription they're taking, or they are using multiple substances, or there's just something going on. And so whether it's causal to their mental health presentation, if it's co-occurring, if it is the way that they're dealing with their mental health condition, it's still helpful to know this information. Motivational interviewing, I'm sure many of you are familiar. There's days long, week-long seminars on motivational interviewing. These are just a few things. This is how I talk about motivational interviewing, like with primary care providers who don't have a lot of time, like motivational interviewing in 2 minutes or less kind of stuff, because they've only got a few minutes with people. So these are really just the principles. We've already talked about, empathy is obviously just a kind of overriding principle always that we want to healing communities and healing individuals happens in human connectivity and authentically connecting with another person. The way that we talk about people when they're not in the room affects how we treat them when they are in the room. Try and remember that there are no difficult patients. There are challenging encounters for a variety of reasons with patients, and it's certainly good to talk about those with your colleagues and in supervision. But people are not difficult. It's sometimes the relationships that we have with them or the conversations that we have that can be difficult. Don't argue with people or try and convince them that they're wrong. That's not great. Developing it just digs people in further. You could try that with any kid. Tell them to not do something and see what happens. Developing discrepancies is really helping people paint a picture of what their goals are. Treatment planning is really important to help people develop a vision of who they might be if they decreased or stopped using substances the way that they are. And then sort of look at, well, okay, how are the choices that you're making now maybe not consistent with the picture you're painting of what you want to be doing or who you want to be or your best version of yourself. When people are resistant to change, it's okay. Change is really hard. You can just hang out with people in their resistance. That's all right. And that might look like they're irritated at you. And just understand that most people are not jerks. Very few people are just jerks. There's some, but there's not that many. Most people, if they're coming across as argumentative or agitated or irritable, it's because they're scared, they feel threatened. If somebody has been depending on heavy alcohol use or some sort of drug use to cope with their mental health symptoms and they feel that they need that, it's very scary to talk about stopping it or decreasing it. So I don't try to push people out of their resistance. Just wait until they're ready and then be with them where they are and support their own confidence and growing into confidence that they can succeed. One of the questions that's always great to ask is, has there ever been a period of time in your life when you weren't drinking like this or maybe not drinking at all? And sometimes people will say, yeah, when I was pregnant, I didn't drink. I didn't drink the whole time I was pregnant or breastfeeding. And then I started drinking again as soon as, I wasn't anymore. And I think that's when you say like, wow, that's a long time. You're talking about like a year of not using alcohol at all when you just told me that you depend on alcohol to be able to sleep and cope with stress. How did you do that? That's amazing. And let people tell you their success stories and celebrate that with them and find opportunities in those successes. These are a few slides, and I won't go into in detail because it's a lot, but I want to make sure we leave time for questions and for talking. But I did include them here because I think this is helpful for, I think, all clinicians to just have a sense of the medications that we use for substance use disorders. Naltrexone is a really good choice for a lot of people with alcohol use disorders. It actually can also be helpful with all sorts of compulsive or self-harming behaviors, but compulsive alcohol use is one of them. People can drink while they're taking it. It just decreases their urges to drink. Interestingly, apparently Ozempic is doing the same thing. There are some emerging studies coming out now that for people with diabetes who are prescribed Ozempic, their cravings to use similarly are reduced. Also cravings to gamble. Very interesting stuff coming out with Ozempic. So for people with co-occurring diabetes and alcohol use disorder, there are some emerging opportunities. The injection, it's called Vivitrol is the brand name. Naltrexone can be injected in just monthly in your primary care practice or somewhere in the community, and then you don't have to think about it or take a pill. Acamprosate is for people who have kidney problems. That's when it's similar to naltrexone, but naltrexone's not a big deal if you miss some doses. The Camprosate, you have to take it 3 times a day, and it's processed through your kidneys. So for a lot of older adults, it's not a good choice for that reason. Disulfiram is what we call Antabuse, is the brand name. You guys have probably heard of that. That's the one that makes you violently ill. Not great for older adults if people drink. There have definitely been some people who will swear by Antabuse, and I've heard people say it saved their life. There was no other way they could have stopped drinking. I prescribed it many years ago, a couple of times, and had people drink on it and get violently, horrifically ill, and I felt terrible and do not want to do that to people. So it's also for older adults can be can cause cardiac and liver problems. And then there's opioid use disorder. We're often more familiar with these medications. So there's methadone, where currently still for addiction, when you need methadone, you have to go into a clinic that is for methadone. I'm hopeful someday that will change and you will be able to get that in more spaces in the community. Buprenorphine, Suboxone is a good choice for a lot of older adults who are struggling with opioid use disorder. For people with severe opioid use disorder, the risk of overdose, accidental overdose, and death is extremely high for older adults. The relative risk of Suboxone is much, much lower. And naltrexone can also be used for opioid use, but it is a tough one because you have to be completely abstinent from opioids for about 2 weeks. And it is a complete blocker of opioids, so they won't work at all. But if you are using them and then you get naltrexone, it will cause you to go into what we call precipitated withdrawal, which you'll have very sudden, painful withdrawal. We don't want to do that to people. And then just referring. So just thinking about, like, if you are a person who is a specialist in addiction or in primary care or in mental health, like, who else do you want to include in your treatment team? If somebody would benefit from case management, they may be eligible for all sorts of services, for public transportation, housing. Always screen for intimate partner violence or for elder abuse and for elder abuse. There is a tool, I didn't include it here, but it's called the HITS, HITS, that you can find online. It's a public domain. It's a great, like, super fast screening tool for intimate partner violence. It doesn't just ask about, like, people in the household or about your partner. It asks about verbal abuse and coercion. It's a really good, very quick screening tool. So highly recommend that you do that, because people often don't even realize. I had somebody screen positive on the HITS last week, an older lady, and I said, geez, like, this verbal abuse piece looks off the charts. What's going on? Because she had said that she lived alone, and she said, oh, my daughter loves to scream at me and call me names and, throw stuff when she comes over to borrow money. And I was like, well, geez, well, this is going to be a very different conversation than I thought we were going to have. But she didn't think of that as abusive. She just thought of that as, like, part of her family dynamic. So it can, in a really, non-judgmental way, open that conversation. Quick note on the community reinforcement approach. There is research on this. It is very interesting. You can find the whole giant pamphlet online that tells you all about how to do it. You would need probably a grant to pull this off, and good luck right now with that. But it would, there are components of it that are really useful. And if you look down, like, this is really what it is. And you look at these pictures, it's doing activities in the community that are meaningful to the individual. So cultural activities, hobbies, finding out what they like to do, what's interesting to them, helping people find community and adopt a life. So the emphasis is not on stopping substance use. The emphasis is on finding a life worth living and helping people to do that. So that's something that we can do without following this whole, like, prescriptive program, and building a sober network of people, even if what that means is finding an activity that doesn't center around alcohol or where everybody isn't using cannabis, like taking a cooking class or a yoga class or just something that you enjoy doing that doesn't center around substance use. It's surprising to some people to come to realize when we talk to them that all of their social activities are related to use of substances, even if they don't have a substance use disorder. And then, the reality is that only 18% of facilities, places that treat addiction, have programming specifically for people, for older adults, or accept Medicare. So it can be really difficult for people to access specialized treatment for people who do have a severe use disorder and need that level of care. Frequent, like for methadone, as we said, having in-person evaluations, having to go physically and get it. I mean, we know transportation in Maine this time of year is very dangerous and difficult for older adults to get out of their homes sometimes. So there are some barriers they experience, transportation, again, social determinants that other people may not. Also having complex and multiple different kinds of medical issues will sometimes just screen you right out of a program. Like, well, we're not going to manage someone with urinary incontinence, or we don't have we don't have the nursing staff here to manage someone who is a fall risk. Well, that's going to rule you right out if you are an older adult who is ready to seek help. And then this piece, I just want to note that you will care for and meet a lot of people who are living with somebody, partnered with somebody who is struggling with an addiction, whether it's lifelong, later in life that it develops, and just helping them to help themselves. Al-Anon is still a great organization. It's been around for a zillion years and it's still awesome. There's a lot of online groups available. You can Google. I never tell people to find things. I always do it with them. I don't think that's enabling people. I think that's helping them, which is what we should all be doing for each other. So if I know how to find something, I'm going to help them find it. So if people are interested in in-person Al-Anon meetings, you can help them find those, or support online, or any kind of peer support. But these are just some tips to help them as you're counseling people who are living with somebody who is struggling with substance use, about how to support them and also take care of yourself. In healthcare, we talked about screening, frank conversations, be direct, be honest. I always tell people, the good news is you'll never have to wonder what I'm thinking. I will tell you, and we'll talk about it. And I'm going to be honest with you. And my hope is that you will be honest with me as well. So if we are doing urine drug screens for some reason, whether it's because they're being prescribed a controlled substance, or because they're on Suboxone, or because they are mandated to have them, I'm not going to expect that those will always come back the same way. I mean, they may come back positive. If you have a return to use, that's part of recovery for some people, but I am going to expect that I won't be surprised, because you're going to let me know when something happens, because you're not here for me. This is your treatment space. You're here for you. It doesn't make any sense to lie to me. And lots of people who have, I mean, it's important to say that out loud, because addiction, there's a lot of shame in addiction, especially with older adults, and hiding and isolation. So really saying out loud, like, remember, you're here for you. You're not here for me. It doesn't make any sense to lie to me. I'm just here to support you. Let me know what's going on so I can help you. I can't help you if I don't know. And being non-judgmental when there is a return to use, and not stigmatizing that, is incredibly important. People need more support and not less when that happens. It broke my heart a few years ago, like several years ago. They'd have a positive urine drug screen, or someone would find out that they'd been trafficking medication, and they would be just kicked out of the whole practice, like kicked out of the whole organization. What good is that? Where are they going? That means somebody is struggling and needs more support. It doesn't mean you keep prescribing irresponsibly. It means that you offer them support and a non-judgmental space to heal. Explain about alcohol and polypharmacy. And just a note on suicide. Suicide rates have increased significantly in the last 20 years for men and women who are over 55. The suicide rate increases more and more with age for men. Men are, especially in the state of Maine, are more likely, I can't remember, I think it's like 40% more likely to own a firearm. And that is the reason that they're more likely to die by suicide than women in most cases, because women will often attempt suicide by overdose or by some other less immediately lethal method. But men who have anyone who has guns in the home is more likely to die by suicide by gun. And men are more likely to have guns in their home. So, and these are the primary risk factors: loneliness, social isolation, grief over loss of a partner, and diminished personal autonomy. Always talk to people about, palliative care as they're struggling, hospice as their health starts to really deteriorate. Remember to have conversations with people about what makes their life worth living, what is most important to them, like what is the thing that makes them glad that they're still here, and really lean into those protective factors. Increased substance use is a risk factor for suicidal behavior and a warning sign. So again, we talked about naloxone and making sure that it's in the households of anybody who is using prescribed or illicit opioids and benzodiazepines or benzodiazepines. That 988 line is, man, is that thing wonderful? That's the best thing the federal government ever did. I don't know if you guys have experienced this, but if any people call 988, it's not like the cavalry swoops in. I always tell people, like, there's no helicopters. You can call 988 or text them like, I need help, and they'll screen for suicide risk. But if you say, no, I'm having a panic attack and I have no one to talk to, there'll be a clinician that will walk you through a grounding exercise, or will just connect with you and provide you with some support. I've had a lot of people do that. It's been wonderful for older adults who are struggling with social isolation. It doesn't mean that they should call to say hi, but if they feel like they're in crisis, this is important. It is true too that it is a frustration experience sometimes that older adults come in a lot to primary care and medical settings, have many medical appointments. I have some older adults in my family that make many medical appointments because they like the support and the attention that they get. So that's not a bad thing, right? We all need that sense of community. It's just about finding someplace else that isn't a medical facility, somebody else that they can connect with. And so that is the gist of it. I know there's not that much time left, but there's a few minutes, and I would be happy to hear any comments or questions at all. And thank you so much.
Thank you so much, Jesse. Cassandra shared some great information about that people calling into main care food stamps are not given additional resources for those that do not qualify or do not receive enough help. It is not in the job description. And so there is a pamphlet that is physically available in the DHHS office, but she and I are now chatting back and forth. She's going to send me the virtual copy of it so that I'll include that in the follow-up email. More resources, and the DHHS offices have them for their local community. So there's going to be, it'll be a link to lots of pamphlets.
Great.
And Cassandra also said that they found that patients with the highest numbers of overlapping opioid and benzos prescriptions are 64 plus age bracket. Any suggestions for programs such as the PMP that promote prescription drug prescribing, dispensing, and use of prescribed controlled substances to identify the high risk and accidental overdose?
I mean, any older adult who is prescribed benzodiazepines and opioids is at high risk, or opioids, either one of those. I mean, the way that people metabolize medications is much slower and different than they do when they're younger. Making sure that their prescribers have that education. A lot of what happens I will say anecdotally, as someone who's talks to lots and lots of primary care providers, is that they love these patients. They don't want to have a conversation where somebody feels like they're being accused of misusing their substances. So it's about helping primary care providers and medical providers have these prescribers have these conversations in a way that partners with the patients. Like, hey, I don't know if you're aware, but even if you I know you're in a lot of pain and we've been prescribing this medication, but even if you take it as prescribed, you're at a really high risk of your breathing slowing down so much that you could stop breathing. So we need to make sure we talk about how to keep you safe. there's really not a good reason to prescribe both opioids and benzodiazepines to an older adult. That is a big red flag. That means a prescriber needs some support with their prescribing habits, and they may not be aware, because nobody wants to kill people, right? Like, nobody in medicine is out to do that. So it betrays like a real lack of education and understanding, or sometimes ability to have those nuanced, difficult conversations. I can tell you, as a person who's had a zillion of those nuanced, difficult conversations with people, that it can be the most wonderful thing for your clinical relationship if you have those conversations compassionately and hold space for people, even if they've been diverting or misusing medication, and you're still there and you still want to work with them and you still care that they're anxious and sad and lonely, that's a huge, huge intervention. So I think we just need to do more to help providers to do that more effectively.
Thank you so much. I also want to direct everybody to you. Please put any more questions in the chat. And if you have other questions or you think of ones later, please email me and I can pass them on to Jesse. We're always happy to answer more questions. Thank you so much, Jesse, for your presentation. It was wonderful. And we hope to see you all again soon. And happy Valentine's Day.
Happy Valentine's Day. Have a good day.